Okay, I think we might kick off. So good afternoon. Welcome to the National Ageing Research Institute's fortnightly seminar series. My name is Frances Batchelor and I'm very much looking forward to chairing this session today, in which we are going to launch the What Do Older People Want from Their Healthcare report, a very important and interesting piece of work. I'd like to start by acknowledging the Wurundjeri Woiwurrung people on whose country our office is located. As a national organisation, we acknowledge the traditional owners of the lands and waters across Australia. We pay our respects to elders past and present, and to all Aboriginal and Torres Strait Islander peoples, including members of the Stolen Generation. So first, a little bit of housekeeping regarding Zoom. At the conclusion of the three speakers, we will have some time for Q&A. If you have any questions, you can submit them through the chat function at the bottom of your screen. You have a tab there, and you can open that and submit questions as you go along. And of course, at the end of the three speakers, you can also unmute yourself and put your camera on and ask a question live if you would like to as well. So today, I'm very much looking forward to the presentation. We're going to have three speakers. First up will be Nicole Doran, then we will have a presentation from Amy Parker, and finally a presentation from Gerard Mansour. So first up, we will hand over to Nicole. Nikki is the Manager of Chronic Care and Older People Priority Population Groups and Communities within the Commissioning and System Improvement branch of the Victorian Department of Health. So try saying that before you've had your coffee in the morning. It's a long title, but we're very happy to have her here today. For almost 2 decades, both the Department of Health and NARI have worked together to support the development and implementation of government policies relating to the care of older people in Victoria. And Nikki's department has commissioned this work in looking at what do older people, specifically older Victorians, want from their health care. And so with that, I'd like to welcome you, Nikki, and hand over to you to say a few words.
Thank you, Frances. Good morning, everyone. It's still morning. Oh, no, good afternoon, sorry, and welcome. I'd like to just start by acknowledging the traditional owners of all the lands that we're meeting on today, and pay my respects to their elders, past, present, and emerging. As Frances said, I work in the department, and I've been lucky enough to have been able to focus on improving care for older people really since starting in the department many years ago. And over this time, we've been able to maintain a strong collaborative relationship with NARI, who have been contributing to building the evidence we need in order to shape and deliver evidence-based policy. So today, I just plan to give you a bit of a flavour about the department's strategic priorities and talk about why this project was commissioned, why it's so important, and what we need to do with the findings. So the department's focus on older people has increased over my time in the department, and our recent restructure, with the very long names for everything, apologies for that, but it has seen older people recognised as a priority population group within the Health Service and Aged Care Policy Improvement and Engagement branch. And this is in addition to the specific hospital and aged care policy and operations focuses in other teams. I thought I would just share some of the division's key strategic priorities with you. So a key objective of the department is that we want all Victorians to experience high quality and personalised health care delivered by a strong health and community care system that's committed to improving the health and wellbeing of communities across Victoria. Now, within our Commissioning and Service Improvement Division for 2021-22, we have 4 key overarching goals. They are to have a health and community care system that's responsive and accessible to all Victorians, that we have an efficient health and community care system that continues to meet the growing needs of Victorians, that the delivery of connected care is through engagement with a supported sector, and that healthcare services that respond we do have healthcare services that respond efficiently and effectively in the event of an emergency. And we've certainly had some disruptors recently. So we will probably all know that as key users of our health service system, it's easy to see the importance of these goals for older people. Some of the things that we're specifically doing towards achieving these goals include we are working on improving pathways and models of care and early access to specialist geriatric services, including through expanding and strengthening our residential inReach services. We're developing and piloting a frailty screening tool that supports early access to a specialist geriatric model of care for older Victorians who are vulnerable to avoidable harm in hospitals. And this also links with the Better at Home initiative and community-based approaches. And certainly care close to home remains a key priority. So we're continuing to progress the public sector residential aged care modernisation strategy in metropolitan Melbourne, and that will replace outdated infrastructure with purpose-built facilities to support contemporary models of care. And Mari's also been commissioned to undertake work to determine this model of care. And of course, with the Royal Commission, we're preparing state-funded aged care services and implementing reforms in line with recommendations, including legislative amendments to medication management in residential aged care facilities, home-based assessment model reforms, and health and aged care interface initiatives, and also workforce and funding model reforms. So there's a lot of work underway, and these are just some examples of that work. So the department has maintained a focus on improving outcomes for older people, but really we've relied on anecdotal evidence when thinking about what this actually looks like from an older person's perspective. And I think over time we have improved our engagement with older people, seeking collaboration on advisory groups, which has been critical to shaping policy, but this also comes with some limitations around the breadth of the consumer representation we can have. We've been increasingly listening to the voices of consumer advocacy groups such as COTA and the Health Issues Centre. So given that older people are key users of health and community and aged care services, how can we really design and deliver personalised health care for them if we don't truly know what's most important to this key group of service users? Whether you're a clinician, a service provider, a researcher, family member, carer, or policymaker, we all share a focus on meeting the healthcare needs of an important and growing population group, which is older people. In order to do this effectively, we need to know what matters to older people as they age and their priorities for their healthcare. This sounds simple, and I know as policymakers we make a lot of statements and assumptions about older people's priorities, but interestingly we've had very little evidence about this. So in order to address this, the department commissioned Mari to undertake research to determine what older people want from their healthcare as they age, so that we do have evidence that can inform future policy development, so that we can enable the system to appropriately respond to what older people have told us they want, which hopefully should result in better experiences for their healthcare and better outcomes. So I feel really privileged to be launching this important report. It reflects the voices of nearly 300 older people. And as clinicians, as researchers, as policymakers, it's so important that we're listening to them and that their voices are reflected in any research, policy work or improvement work we undertake to ensure that our recommendations and actions are actually meeting what we now know older people want. So I would really sincerely like to thank the team at NARI who have undertaken the research and commend this significant report to you. At the department, we will certainly be sharing these findings with internal and external colleagues and using it wherever possible as our evidence base to support policy work. And I really urge you to read the report. It's really digestible. I urge you to share it broadly and make these findings a key consideration when working to improve care and outcomes for older people in whatever capacity you engage or interact with them, their families and their carers. So thank you.
Thank you very much, Nikki. I think we should really be thanking you and your colleagues, including Andre Catrice at the department, for your ongoing leadership in this area of work and your commitment to developing evidence-based policy in the area of older people and their care, both within the health and aged care systems, really needs to be commended, and you should be congratulated on that. So thank you very much.
Thank you, Frances, and hopefully we'll have an ongoing longer-term partnership.
Yes, very much looking forward to that, and for this report to be publicised widely, as you mentioned. So I'd now like to introduce Amy Parker, who is going to provide you with an overview of the findings of this work. Amy is a research fellow within the Clinical Gerontology Division at NARI. She has a clinical background in physiotherapy and significant project management experience in the public healthcare system. She leads NARI's program of work for the Victorian Department of Health and regarding older people policy. And she's committed to supporting the implementation of evidence-based practice into community and hospital care. She's also a member of NARI's Knowledge and Research Translation Impact Committee. Her particular areas of interest include clinical governance, quality and safety systems, workforce development, innovative models of service delivery, and health literacy and environmental design. And as I said, Amy's just getting her presentation up on to Zoom.
It's not behaving, so I'll just have to do it like this.
Which I think is fine. We can all see that.
Excellent.
But yes, Amy, over to you to provide us with an overview of the results of this survey and of the report.
Thanks, Frances. Good afternoon. My name is Amy Parker, and on behalf of the NARI project team, it is my pleasure to present an overview of the What Do Older People Want from Their Healthcare project. Before I begin, I would like to acknowledge the traditional owners of the land on which we are meeting today and pay my respects to their elders, past, present, and emerging. Victoria has a large and growing population of older people. Over the last 2 decades, the number of Victorians aged 85 and over has grown by more than 130%, faster than any other age group, with population ageing expected to continue to intensify into the future. Older people have been identified as significant users of healthcare services in Victoria. Despite this, to date, little is known about what older Victorians want or expect from their healthcare as they age, or how these priorities may change over time. There is also a need to understand the influence of interactions with the healthcare system at different points throughout the ageing process and across the care continuum. Knowledge about this is important because many of the challenges that confront individual older people as they age can be predicted, planned for, and amended. The What Do Older People Want from Their Healthcare report, which is being officially launched today, presents the results of consumer consultation that was conducted by NARI on behalf of the Victorian Department of Health. It explores what older people and their carers consider important in relation to their health and wellbeing throughout later life by focusing on 6 identified stages of ageing. While these stages of the typical ageing trajectory are in keeping with general trends across the life course for the general population, it is important to note that there is marked diversity in how the changes are experienced by older people. Consultation was targeted at Victorian residents aged 65 or older, or 50 years and older for Aboriginal and Torres Strait Islanders, and included people residing in the community or in residential aged care. Carers of older people were also included, regardless of their age. For the purposes of the project, a carer was defined as someone who provides unpaid care and/or support to a family member or friend aged 65 years or older. Ethics approval for the project was obtained by Austin Health's Human Research Ethics Committee. The project method incorporated 3 targeted phases. In the first instance, 7 semi-structured face-to-face focus groups were conducted with older people and carers of older people in metropolitan and regional Victoria. Qualitative data was collected concerning the needs, expectations, and priorities of participants regarding their healthcare. This data informed the development of a project-specific Facebook page, which gathered 1,285 views over a 2-month period, in an attempt to obtain further information from older people who may have been unwilling or unable to attend a face-to-face focus group. Online participants were invited to contribute to targeted questions, open inquiries and polls regarding issues associated with ageing, designed to encourage discussion about healthcare preferences and priorities. Thematic analysis of the qualitative data obtained from both the focus groups and social media consultation, in addition to a review of peer-reviewed and grey literature, was used to inform the development of an online mixed method survey targeting older Victorians. A total of 386 online surveys were received. The online survey contained 35 questions and collected both quantitative and qualitative data about the needs, expectations, and priorities of older Victorians across different stages of later life. Survey questions were organised into sections that reflected the 6 identified stages of ageing, which I will discuss shortly. Carers were asked to answer all questions on behalf of the older person that they provided care for. Demographic data collection included gender, age, living situation, employment status, and carer status. Participant health status and personal experience relating to hospitals, aged care services, and end of life was also included. While the survey was primarily an online survey, hard copies were also provided on request. Regarding the demographics, majority of survey participants were women aged 65 and over. The average age of participants was 72 years, with ages ranging from 30 to 95. 10% of responses came from carers under the age of 65, responding on behalf of an older person, hence the person aged 30. The most common carer relationship was a child caring for a parent, followed by spouses and siblings. Due to a significant recruitment effort and uptake among regional community groups, there was good representation across Victoria. While 57% of responses came from metropolitan Melbourne, 34% of survey participants reported living in regional Victoria. And now to the results. During periods of healthy and active ageing, older Victorians prioritised taking an active role in managing their health. A positive outlook on life, healthy eating, access to specialist medical services such as geriatricians or cardiologists, and meaningful social interactions with family and friends were also thought to be important. Participants saw the need to be proactive and take a personal responsibility for one's health, which included both self-care and seeking professional assistance when required. This was flagged as particularly important to people living in regional and rural Victoria who identified difficulties accessing appropriate medical specialists due to geographical location. Social interaction with family and friends was highly valued, largely because it allowed older people to feel included and that their opinions were respected and listened to. It was felt that maintaining and managing the health of older people could be encouraged by improving community awareness of healthy ageing practices and building age-friendly environments to promote physical activity and social participation among older Victorians. With more essential health services moving to online service platforms, including telehealth, it was also identified that older Victorians need to be provided with opportunities to upskill in computer and digital literacy. User design that considers older people is also important when planning online health service delivery platforms such as websites and phone apps. Ageism was also identified as a potential barrier to inclusion, social interaction, and physical engagement in the community. Public awareness of ageism needs to be increased to ensure that all older Victorians feel like they belong and are both respected and listened to. Facilitating access to mental health services could be of value in supporting older people to have a positive outlook on life and be motivated to undertake health-promoting behaviours, which were considered key to maintaining emotional wellbeing. And finally, while older people recognise the importance of having their own GP, many did not feel that their health was well managed by their GP or that their GP was well informed. They indicated that access to a consistent GP was hard to achieve and that they weren't often asked about their healthy ageing goals. In managing multimorbidity and frailty in the community, older Victorians valued the opportunity to age in place. This goal was assisted by other factors rated as being important, including having effective transport in the community, adequate financial resources, age-friendly and safe environments, and proximity to healthcare services. Survey participants outlined many benefits of living in their own home for as long as possible, including promoting independence, maintaining a routine, and allowing individuality and a heightened sense of self. Despite this, participants were anxious about having adequate financial resources to remain in their own home. This included maintenance costs, healthcare costs, and expenses involved in modifying their home to suit their ageing needs. Concerns around the local environment were also raised, with participants having a great deal to say about cracked, overgrown, or steep footpaths that compromise their mobility in the community. Age-friendly transport options, including public transport and taxi services, were acknowledged as a particular obstacle for older people in regional Victoria, where large distances between healthcare services often requires the use of a car. Actions and resources that enable ageing in place, such as in-home services, in-home modifications, and support to enable spouses, family, friends, and neighbours to foster connection and continue supplying critical support to older Victorians were considered essential. This also requires local communities to be built and modernised according to age-friendly principles, with infrastructure and safety concerns adequately addressed. Many survey participants reported being unaware of what community-based health services were available to them. While it was generally accepted that public awareness of the My Aged Care system needs to be increased, it was felt that action should be taken to improve its accessibility as a service to older Victorians and their carers. This included improving the usability of the system, eligibility, affordability, and waiting times for assistance and packages. When requiring healthcare in a crisis for sudden health issues, often involving acute hospitalisation, older Victorians appreciated knowing what was going on with their care. They also felt that high-quality healthcare, being listened to, being treated with dignity and respect, and receiving treatment in a timely manner were important. Participants had many stories about feeling forgotten or anxious because they were not well informed about management plans. They wanted to be included in their care, listened to and respected by hospital staff, be advised of who to ask for help and advice, and have avenues to provide feedback. Clear and respectful communication was considered critical. Survey participants also expressed a desire for person-centred care, but acknowledged that health professionals have to work by a schedule that often cannot always accommodate an individual patient's preferences. It was felt that appropriate staffing levels played a key role in facilitating timely care delivery. Opportunities must be provided by hospital staff and systems for older people to partner in their healthcare. Ensuring the provision of quality healthcare was felt to be underpinned by adequate staffing levels, timely identification of care needs, flexibility surrounding protocols, effective communication, and a focus on person-centred care that meets each individual's needs. With the quality of public hospital food largely considered inadequate by survey participants, both in meeting nutritional needs and being palatable, suggested improvements to improve food consumption included the provision of mealtime assistance and food packaging that can be easily opened. Access to free parking for patients and visitors at public hospitals was also highlighted as a significant issue for older people, with complaints regarding the cost of hospital parking one of the most frequent comments relating to hospital care. As part of regaining independence after being unwell, including recovery from an illness or injury, older Victorians thought it was most important to maintain a positive attitude, have a discharge plan when leaving hospital, and have a strong support system to assist at home. They also valued both home-based and community-based medical, nursing and allied health services. Survey participants agreed that when recovering from an illness or injury, it was important to return home as soon as possible. However, to do so successfully required a clear discharge plan when leaving hospital. Strong support systems, as well as access to comprehensive healthcare services provided in the home and/or in the community, were also considered an important part of a successful recovery. Just under half of survey participants who had been admitted to hospital within the last 5 years reported that they had received a discharge plan. This could be improved by incorporating discharge planning into e-health record systems at a hospital level and, with the consent of older people, ensuring that copies of discharge plans are communicated to older people's carers, key supports and healthcare providers such as GPs. Screening for social isolation or living alone without anyone to assist with tasks at hospital admission may identify the need for additional support following discharge. In this case, hospital staff could enhance the support system of isolated older people by linking them with local support groups, welfare payments to supplement low income, affordable or free transport, domestic help, and community-based services upon discharge from hospital. Plans regarding community-based and in-home services following acute illness or injury need to be communicated in a way that helps older people access the services they need to assist them in regaining their independence. In regards to needing specialist aged care support, older Victorians expressed a strong desire to remain in their own home for as long as possible and only moved to a residential aged care facility when they could no longer be cared for at home. They valued planning the transition to residential care ahead of time. Once in residential aged care, older Victorians valued high quality care and the ability to continue to be myself. Many survey participants described how they feared being separated from their spouse, social isolation, or the loss of their individuality and independence if requiring residential aged care. A number indicated that they would only move into residential aged care if they could no longer be cared for at home, or if they felt that their care had become a burden to their spouse, children, or loved ones. Trust regarding the quality of healthcare in residential aged care was identified as a significant issue. Despite the universal reluctance to live in residential aged care, most participants acknowledged that if the need did arise, it would be far better to have planned your transition ahead of time. Several participants described negative experiences of scrambling to find a place for a spouse or parent when they couldn't be discharged home from hospital following an illness or injury. Older Victorians, again, indicated a strong desire to age in place, and where this is their preference, maintaining older people in their own homes and communities for as long as possible should be a priority. Survey participants identified actions to facilitate remaining in the community that could be supported by health and housing policies. With few participants suggesting that they had made plans for a future move into residential aged care, education regarding the importance of planning for future care requirements before a loss of capacity to make decisions or before an emergency could be beneficial. Particular concerns raised by older people regarding residential aged care included poor care, isolation, and loss of independence. This is often linked to perceptions of understaffing, inadequate training, lack of empathy, and fears of being socially isolated and dependent. Poor perceptions of residential aged care appear to be felt across the community, which suggests that actions will need to take place to improve public confidence in these services. Moving to residential aged care from hospital was reported by older people and their carers to be difficult. This was also the case with accessing hospital care when living in residential aged care. Therefore, some thought into the interface between hospitals, transition care facilities and services, and residential aged care could be of value. Finally, when requiring end-of-life care, older Victorians valued being treated with empathy and respect, effective pain management, and family-centred care, which includes, informs, and supports bereaved family members. Older Victorians wanted access to appropriate palliative care services, as well as written plans and verbal conversations to document their preferences. Respect for one's choices was a major theme, including choices in family involvement, location, pain management, and euthanasia. Euthanasia, or voluntary assisted dying, was highly contentious, but comments tied this closely to the need to respect one's choices. Older Victorians seek access to appropriate and timely palliative care services that maintain dignity, are family-centred and respect and honour the choices of the individual. Majority of older people agree that conversations around end-of-life care need to be held prior to medical emergencies. However, the awkwardness of the subject matter is a barrier. Honest but sensitive conversations and careful timing should be considered. It is uncertain whether participants were aware of the meaning or purpose of palliative care services, with majority indicating that they had made no plans regarding their end-of-life care. Greater public awareness is required to encourage older Victorians to have the necessary conversations and make the necessary legal plans required for them to receive the care they desire at end of life. Regarding the carer experience, many survey participants described their care and responsibilities as a significant burden and did not feel well supported by other carers or services. As a result, carers of older people may be in danger of delaying or overlooking their own health needs. Greater investment into carer support, including appropriate and accessible respite care and transitional care options, could help reduce carer burden, improve the health and wellbeing of carers, and ultimately keep older Victorians ageing in place for longer. So, what do older Victorians want from their healthcare? Across the ageing trajectory, survey participants were grateful for the opportunity to provide feedback over the course of the project. This indicates that older Victorians want to have greater and more regular input into healthcare policy development, as they are well aware that these policies and frameworks will have a profound impact on their ability to age well. Advocacy was also a theme that came to the fore. Older people indicated that they wanted someone to help them and speak up for them during hospital stays, in recovering after hospitalisation and/or injury and illness. Older Victorians also value options and alternatives when it comes to accessing healthcare services, whether it is a choice of GP, in-home service providers, residential aged care facilities, or access to specialist palliative care services such as voluntary assisted dying programs. They also want to be able to make informed decisions regarding their health, and then to have those decisions respected and acted upon. Regional and rural Victorians in particular require a greater degree of choice, which may be improved by the further development of telehealth and other technology-based healthcare services. The health and aged care systems are complex and often difficult to navigate. Many older people find the My Aged Care system challenging to use, and some reported being left or rushed to make decisions in a hospital setting. Survey participants reported a need to evaluate and reset health and care settings to meet the needs of older people. Improvements are needed to not only ensure that older Victorians are able to find the information and practical support that they require. Oh, sorry about that. Hang on a second. But that the environment they live in is as accessible as possible. This includes strategies to accommodate varying degrees of computer literacy and personalised alternatives to current online practices, as well as promoting age-friendly local environments. Not all older people have a comprehensive understanding of the scope and purpose of many common healthcare services and supports. Many are confused as to what to expect from in-home services, GP services, residential aged care facilities, and palliative care services, among others. In order to recognise and appreciate quality healthcare, older Victorians require more effective communication strategies to inform them as to what constitutes quality care and establish appropriate expectations. Awareness of quality care could be improved through targeted public education programs and more effective communication from healthcare service providers to accurately establish consumer expectations. Finally, the findings of this project support a case for better integrated care for older people to create a system-wide approach that works to address the demands arising from an ageing population and better supports people with multimorbidity, functional impairment, and other long-term conditions. There is evidence of benefits when health and care organisations and services work together and coordinate the care they provide around the needs of older people. Developing integrated services can overcome barriers between different health and care services and levels of care, as well as types of care and providers. This could improve services that exist separately from each other, but are often all relevant to an individual older person, their health or care needs, or a health event, and facilitate the provision of the right care at the right time in the right place. If you'd like to read the full report from the What Do Older People Want from Their Healthcare project, please visit the NARI website via the link or the QR code. I would like to give a big thank you to all our focus group, social media and online survey participants across Victoria. I would also like to thank the What Do Older People Want project team at NARI, including Dr. Jessica Cecil, Jess Barry and Associate Professor Francis Batchelor, as well as the Victorian Department of Health for their support.
There you go. Thank you very much, Amy, for that comprehensive summary, and we can get to some questions and comments after the conclusion of Jared's presentation. But what struck me really was, I think, one of the final comments you made about the right care in the right place at the right time, and how that supports the need for the integration of the system, and that we very much still have systems that exist in silos. And I think the main points, I mean, this could be used as a excellent roadmap in terms of how best to integrate systems and where to set priorities. Okay, well, it's with great pleasure that I would like to introduce Jared Mansour, who's going to talk to us and give us a little bit of that overall context in which this report was written from some of the work that he's been doing. Jared is a highly respected and passionate advocate for the needs of older people. In 2013, he was appointed as the first ever Commissioner for Senior Victorians to provide advice to the Victorian Government on issues relevant to senior Victorians. In 2016, Jared's role was expanded to include acting as an ambassador for elder abuse prevention to give older victims of family violence a voice and raising community awareness of elder abuse. Jared's current priorities include isolation and loneliness of older people, prevention and response to elder abuse, and what it means to age well. And one of these seminal reports, Jared's report, Aging Well in a Changing World, was launched in November 2020. And I think the work that we're launching today very much complements some of those findings. So over to you, Gerard, and welcome.
Thanks very much, Francis, and lovely to hear that presentation, Amy. Most informative. I've had a chance, obviously, to look at the report. So I'd like to start by acknowledging the traditional owners of the various lands on which we're all meeting today. I speak to you from the land of the Wurundjeri people of the Kulin Nation. I'd also like to acknowledge them as the longest living civilization in the world and how fortunate we are to be living on their land. I'd like to pay my respects to their elders past and present and Aboriginal elders of other communities who might be here today. Yeah, Francis and Amy, when I looked at this, it certainly does resonate with the work that I did, Aging Well in a Changing World, but it also resonates where older people have moved to in their thinking as a result of COVID and the world we now find ourselves in. And I'd like to just make a couple of connections to the attributes of aging well that I think link very well to the report, but also make some observations about where I think this fits so importantly with where older people are now positioned in our community. If I could start there, one of the things that I've been doing in the last couple of months, and a key part of my role, I've always seen as bringing the voices of older people to key decision makers. And so my report and this piece of work you've done today is, or launching today, is just so important in continuing to bring the voices of older people front and centre to key people, policy and decision makers. And congratulations to Nikki Doran and the team, the leadership of Ewan Wallace for the focus in the Department of Health on the voices of older people. And I think I agree with Nikki's comment. I think there is greater recognition now than at any time in my role about the importance of gathering the knowledge and intelligence of where older people find themselves. I'd make a couple of high-level observations about that from the feedback that I'm getting, and part of that comes through the fortune I have of chairing the Senior Victorians Advisory Group. I think older people sit along a really big continuum about, so where are older people today? There's a group of older people that, of course, amongst the first to reconnect. They're out and about, that have probably already booked their overseas travel, and are reconnecting with life in the same way as anybody else. There's a group of people in the middle that I think I'd describe by a level of hesitancy and uncertainty. So they're sort of doing that, but at the same time, they've got a degree of caution, and they're probably still thinking about wearing their mask when they go into supermarket and cafes and things like that. So there's a degree of hesitancy, but look, overall, they're progressing slowly, not as fast as the first group, but they're gradually moving into reconnecting with the world in which we live in the way that they feel confident. But there's another group, a third group, and it's not a small group of people that continue with fairly high degrees of hesitancy. They've heard messages continually about the vulnerability of older people. You just think of, the death rate figures we tragically see, most days. They're mainly still older people. We've had a lot of that early messaging about vulnerability of older people, and they continue to think in that space. So this particular group probably haven't returned yet to face-to-face meetings. So if they're a member of a U3A, they're probably connecting on Zoom, but they're not getting back face-to-face yet. Or with the men's sheds, they're probably not going back physically into the room at this stage. So you can see how important this piece of work is leading that next generation of thinking about what are the things that we've got to do to help and better enable older people to connect as we move forward. And healthcare and their wellbeing is central to that. And there are three attributes I just wanted to mention very briefly that I think are central to the thinking and sit there as context. And the first one is what I called attribute one, having a positive attitude. The attitude people have is just so central to their well-being. And if they remain overly in an over-cautious environment, in the end, it's not that good for their well-being. And I think part of the challenge for all of us in our conversations with the people close in our lives is to help them get a better balance and understand that reconnecting and finding again that sense of what drives them and inspires them is so central. I think there's a lot of people in our community that have put that in the freezer for a little while, that have deferred decisions and actions about what is it that's going to motivate and drive them. We know quite a few older people have slowed down their volunteering activities or have ceased those altogether. So what's going to replace that as they start, this next phase of reconnecting in life? And how do they find the things that are going to inspire them? Because we know that their attitude and having a positive attitude is just so central to their well-being. And I think one of the quotes that really stood out to me from my earlier research that I think is presented in part of the narrative that you've talked about is when older people said to me, and one of the quotes that I put in my report, "We are so proud and can't ask for help. Some things could be avoided if we asked earlier." So there was already a lot of older people in that mindset before we hit COVID. And if the connection with health services and support, plans to age well, the discharge planning documents, if those things don't come through in a positive and proactive way, what's going to happen is that sense and that fear of isolation is going to continue far longer than it should. So it reminded me a lot about that early work I did around the positive attitude and the attitude that older people themselves take into that journey of aging. The other one that really stood out to me is what I talked about as attribute number two, having a purpose and meaning in life. And of course, for so many of us, that's been jarred through this experience because, the sense of socializing with people, enjoying life, joining groups, getting out and about and traveling. So all the sort of language that older people talk to me about that was central to part of their experience of having meaning and purpose in life, of course, that's been jarred through this whole experience. And so the work that you've just presented is central to thinking about from a health paradigm. What are the things that health professionals can continue to do to enable those conversations with older people, those deeper ones? So when people go and talk to their GP, and I reflected a bit on the submission I did to the Mental Health Royal Commission, often the conversation of an older person with their GP about, say, anxiety and depression leads with a result of them walking out of the doctor's surgery with an antidepressant. it goes, you know, not that much further. And so the work that is occurring about the missing middle, the mental health reform, again, is so central. And the work that you've done here can certainly help to inform the importance of those conversations with older people. One of the things that they said, and carers often said to me when I was consulting on my submission to the Mental Health Royal Commission, is they were felt that between consultations and engagements, they were pretty much left on their own. There wasn't this sort of active planning of, okay, over the next few months, you might find this, or if this happens, this is available, or a document or a resource to guide that conversation. And so I think, you know, a lot of that links back to what drives older people. And when they present, they're not just, you know, a person with a particular issue, they're a person with a particular issue and a whole life around them. And so I think the challenge for health professionals is going to be, how do they dig deeper to understand where an older person is on that whole wellness paradigm as we're moving out of this COVID experience, and not assuming that older people have yet reconnected with their life in the same way as they did before. I think that would be a grave assumption to make from the feedback that I'm hearing at the moment. And of course, the final one that I wanted to comment on, which is the obvious connection, which is why I didn't start with it. I started with those other two on purpose. But being able to manage their health issues, including mental health, is just so important. And the language they so often use, that I was delighted to see it in your report and the commentaries that Amy made, is that word independence is so central to their well-being. And I think they're going to need some inspiration and encouragement on that, given where they are at the moment. I don't think that a lot of older people in that third group and some of the one in the second group that I talked about are intuitively going to move back automatically to that sense of independence of what they had. They'll aspire to it, but they're going to need some encouragement and tools to be able to get that. And basic access to services is so central. And I'll just finish with a comment about how I see their attitude to aged care services. I think there's a real risk for us that the whole experience of COVID, the tragedies we had here in Victoria, the Four Corners programs, the Mental Health Royal Commission, you know, initial report being labelled neglect, it sent a whole lot of messages over a constant period of time about the state of aged care services. My own observation is I think the attitude of older people has gone far lower in terms of confidence to what I see. And yes, there's a whole lot of challenge that exist in residential aged care, and they have to be addressed. But there's enormous goodwill of so many staff in providing, you know, what older people need on a day-to-day basis. And I'm reminded of the fact that there's still going to be a lot of older people that aren't going to be at some point of their life journey safe to be in their own home. They're not going to have the family supports and the other service system around them to do that. So I absolutely understand the critical importance of strengthening and building the home care system and the home care support. But at the same time, we have to have some mind to the fact that the residential aged care system needs to be the best it can be. So that for those people who aren't able to, no matter what level of support they receive, to remain confidently in their own home, they need a pathway to a system that they've got confidence in. And again, I join with you about one of the priorities to think about how do we rebuild that confidence in the aged care system. So congratulations to NARI, the Department of Health, for what I think is the most critical piece of work in guiding the next steps, as so many older people are looking for guidance in returning to the world that they would want to have as a world that gives them more positivity, meaning and purpose in life, and access to health services when they need it. Thank you.
Thank you very much, Gerard. And for those reflections, I think you've made some very, very important points. And it really struck me as well around the messages that come out. They're not targeted necessarily to older people. It's been all about in this post-COVID world of, you know, getting back to work, getting back into the office and so on, ensuring the CBD is lively and business is flourishing, and much less focused on those populations who can do with encouragement and targeted messaging. Okay, well, we now have the opportunity for some questions and comments. And first of all, we have a question from Andre in the chat. Thanks, Amy, for the great overview. He believes most of the interviews and surveys happened before the COVID pandemic. So this is very timely given what Gerard was just talking to us about. Do you think this is a good thing? Or do you think because maybe the findings weren't as influenced by the COVID experience. Can you comment on that?
Thanks, Andre. I think that Gerard has actually answered that question pretty well in what he said already, and I would certainly agree that I think, if anything, obviously this experience has heightened a lot of what we found prior, and that some of these issues around obviously technology, access to health services, social isolation, and mental health issues are only going to be bigger issues that we're facing now moving forward. So I'm sure if we did the consultation now, I think that those themes will be strengthened even further. Did anyone else want to add anything to that?
Nikki?
Sorry, I can't find my little put your hand up button. I think we should probably keep in mind that, I think this is a point in time report, and I think for us it'll be interesting to think about, well, when do we need to review and refresh that? I think probably the disruption of the pandemic has highlighted how quickly things can change and the impact on people's actions and motivations, and so I think it's just important for us as a department too to keep that in mind in terms of, well, when do we need to go back and refresh this? So I think, I think it's probably not I think at the moment it meets lots of needs, and I think it's great information and we really have to use that. But I think we just also need to be alert as to when changes might impact changes in people's thinking around what they want.
And I think that's acknowledged actually in the report as well. Exactly, yeah, as you've said around, at what point do you actually go back and ask the questions again? So,
and it could be that you could ask some targeted questions based on sort of new policy or new programs that are implemented, and then some of those questions could be asked again in a targeted fashion to see the effect of that policy implementation. Okay, we have a comment from Joan. Congratulations to the team and the shared commitment to ensuring older people's voices are heard, and the importance of collaborating to design systems to meet older people's diverse needs. And I think, thank you, Joan, I think that framework of looking at those 6 key stages is really important, because older people are not homogenous. It's an age where there's lots of heterogeneity, and being able to design a system or systems that recognise and respond to the heterogeneity is extremely important. Joan, did you want to add a comment to that? You can just see Joan's got her camera on.
Yeah, thanks. Thanks, Francis, and just huge congratulations and shout out to the team. Fabulous work. And I agree with what you were saying, Francis, that it's a real opportunity here to leverage from the findings to design something more bespoke, to build on the work and take it further, and because the landscape may well have changed. I'm picking up on some of the comments, particularly from the findings related to people in rural and regional areas in particular, and whether or not that has worsened. It's likely to have worsened, as Gerard said, because of COVID. So I think there's an opportunity to, as you say, become more targeted and contemporary and going forward.
Thanks, Joan. Bianca asks whether our study included older people from culturally and linguistically diverse backgrounds. If so, were there different views from them about some of the aspects of the key findings?
That's a good question, and there wasn't anything certainly in the planning that specifically targeted COLD backgrounds. Obviously, with the diversity of focus groups, yes, we had some participants who were from COLD backgrounds, but nothing targeted, and that's something that we identified could actually be of benefit to explore further into the future. So, yeah, absolutely open to looking at that as well.
Thanks, Amy. Anyone else have a question or a comment? One thing I suppose, and I'd be interested, Nikki, in your perspectives on this. I suppose, how specific is this to Victorians? It was conducted in Victoria, but it seems to me the findings are very relevant, obviously, across Australia, if not, internationally. I don't know if you want to comment on that, or did anything come up? Nikki can comment, but Amy, anything that came up in the more detailed analysis that was specific to Victoria?
I mean, I think obviously we've targeted Victorians because, that's our remit and they're the people that we have in our health and community and aged care systems. I expect there will be lots of commonalities much more generally, but potentially also some, more bespoke things to different regions. And I feel like the more you do, the more you need to do, that we've wanted to do this piece of work. We've got this wonderful report, but then there's also more things now coming out of that and opportunities to perhaps target more deep, to drill a bit more deeply about specific groups, which I think is a really important thing to do. And I suspect that potentially would be the case maybe in other jurisdictions internationally. But I think it's I think we've started from a really good base, and I think it will really help us as we do go forward with, policy development for older people.
Yeah, thanks, Nikki. Amy, did you want to add anything?
Only seconding what Nikki said, and obviously on the back of Bianca's comment around coal groups, and that obviously, the ways that different communities work, may have different priorities in terms of things like ageing in place or use of residential aged care. So, yeah, probably looking internationally to major differences, I suppose. But also, yeah, again, if you don't ask the questions, you don't find out. So always need to ask the questions first.
Thanks, Amy.
And I think also Indigenous groups would be really important for us to think about. And yeah, so as I said, the more we do, the more we'll need to do.
We've got one final question from Anita Go. Great report. She will be sharing it. Excellent. Was there anything specific to people living with chronic diseases like dementia or prevention of dementia?
We didn't target any particular conditions as such. Obviously, sections around living in the community with multimorbidity, that may have been raised by participants based on their individual circumstances. Same with healthcare, obviously recovering from acute health issues as well. So not collectively, but certainly reflections based on individual experience of the people who obviously were involved in the consultation.
Thanks, Amy. Well, we have 1 minute to go, which means our time is up, but I'd really like to thank all of our speakers today. Nikki, Amy and Gerard, thank you very much for your presentations and your reflections. Please join me in thanking our three speakers. You can use your clap reactions. And there will be another seminar in 2 weeks' time, and that will be advertised through the usual channels. Thank you very much, and don't forget to download the report and share with your networks.